Thank you very much, and appreciate the opportunity to share some of our thoughts on biomarkers. So we've all heard the term precision medicine. We've all seen the problems of measuring response in prostate cancer. And if we're going to move forward, it is essential that we can actually make measurements that mean something. So while many of us are familiar with how drugs are developed, we're finding few people have actually had to deal with biomarkers from a regulatory framework. So that's what I would like to focus on today, give you some examples of different contexts. When you think about a context, think about the decision that the biomarker result is used to inform. And as we're dealing with regulators and as we're dealing with third-party payers, it is essentially essential for us to show what exactly you will do differently on the basis of that biomarker result or how it will impact on patient management. So I would just like to cover financial disclosures, having had the privilege of working on ARN and MDV 3100. But we also have a program, as you will see, focusing on measurements both in blood and in tumor and putting those in context of informing medical decisions. So here, as you've seen, there's been 6 agents that have been approved in a relatively short time period. But while this has been very, very encouraging for patients, and having been in this field for many years, represents unprecedented progress, it actually also at the same time creates some problems. Because as we saw today, a drug that has efficacy failed to show its survival benefit because post-protocol, patients were able to receive effective therapy. That's very good for the patient, but unfortunately very bad for the drug. And if you actually looked at the size of the PREVAIL trial that was presented today, 1,700 patients were required in order to show the survival benefit as a cushion against the known fact that patients would be receiving subsequent treatment. So clearly the first thing we need is a measurement which will show that the drug is actually working in terms of hitting its target. These are called response indicators. It does not necessarily mean a clinical benefit. We need surrogate biomarkers that will allow a drug to be approved before a survival endpoint, because this is going to become more difficult to achieve. And if we want to practice precision medicine, we need to identify predictive biomarkers which enable us to make the decision whether to choose drug B versus drug A based on the biology of an individual patient's tumor, so that we know that they are most likely to respond. So we've all heard the term biomarkers, and in fact it seems quite simple. But when you actually try to prove what a biomarker informs, there are a very distinct set of rules. First, what's a biomarker? It's something that you can actually measure, evaluate as an indicator of a normal process. We are focusing on pathogenic process, or as I'll show you, responses to a therapeutic intervention. That is something that is given. It could be a clinical parameter, which we do every day. We look at a patient who's sick versus a patient who is not, and immediately we have approached that patient as a biomarker and say we might use an aggressive therapy in the second patient, but not the first. So as mentioned, we are familiar with the indications for a drug. That is what they are approved for. Biomarkers are developed for a specific context of use, and the context of use is the management decision. That could be whether to do a diagnostic test or not, or it can be a therapeutic intervention, whether to recommend surgery or drug A versus drug B, that is influenced by the biomarker result. So before an intervention, we can categorize the decisions as what is a patient's prognosis, that is, what is the outcome for that patient if you do nothing, that is the natural history of the disease in the absence of therapy. We can predict for survival. We can predict for the occurrence of a cancer. Or as we aim to practice precision medicine, we're thinking in terms of prediction. We can identify subgroups of patients in how they would differ in terms of their outcome, whether we're treating them with surgery or radiation therapy, or what their likelihood of response to a drug might be. So in terms of Medicare and other third-party payers, we're thinking in terms, how does that test inform your decision to pick one type of treatment? After we've treated a patient, we'd like to see if the drug had an effect. that is called a response indicator, and I'll show you an example. Importantly, though, a response indicator does not necessarily mean that the drug benefited the patient. And if we want to shorten the time for drug approvals, we need to develop surrogate biomarkers of efficacy, and typically this is looking for a biomarker that can replace the survival endpoint or act as a surrogate for an endpoint. And again, the regulatory guidance for approval of a drug is to demonstrate clinical benefit, which is how a patient feels, functions, or how he survives. It does not necessarily mean, that a tumor has to shrink. So one of the portions of biomarker development that is grossly underestimated is what's called analytical validation, and that is the performance characteristics of the assay. How reproducible is the measurement? What might affect it, which is not an indicator of what it is purported to measure. We had an issue with FDG PET scans, where patients would often receive Decadron pre-treatment, and we found that just giving the Decadron can change the uptake of the glucose tracer. So again, in the clinic, one has to understand how to use the test. If you do, in a prostate cancer patient's a rectal exam, have you changed the result, which doesn't necessarily mean anything. And again, if you actually read the approvals or the clearances for many of the biomarkers, this is quite extensive amount of work. What does it entail? It involves a number of pre-analytics parameters, and specifically, do you collect it in serum or plasma? What type of tube? If you need to ship a sample, how long can it be, how long from the time of blood draw to the actual measurement will the result change or not? The analytic, what is its precision? Is it reproducible? How do you actually report the data? And I'll show you some of the new results that we've been generating with a circulating tumor cell technology, where we're struggling actually how do we show the data and what it means. And afterwards, how do you record the data? And if you speak to Dr. Morris, he can share his experience and how they developed the ways to report PET scans. And I'll show you an example where you can see a different result if you measure 1 or 2 lesions versus all of them. But the important thing is that if you're using the result of the test to select treatment A versus treatment B, and this must be locked down, and for a biomarker that will be used, for example, a measurement of a mutation in a pathologic specimen, again, this has to be locked down, it has to be approved, and it cannot be changed. Once you have your assay, you can begin the process of clinical validation. This is analogous to the phase 1, phase 2, phase 3 trials that are done with drugs. And this is generating the evidence, or show me the money. Show the proof that, in fact, this biomarker result will mean something in terms of how you approach the patient. And finally, the area of clinical utility, grossly studied in clinical trials, because just showing that there is a significance between the result with or without the biomarker doesn't mean that it has utility. So here you have to show that by using the result of the test to change management, to guide therapy, improves the outcome, the risk-benefit ratio for the patient in relation to not having performed the test. So again, the identification of a mutation in a receptor tyrosine kinase says this patient is most likely to respond to this particular drug. So arguably, that patient is going to benefit versus someone who does not have the mutation in their tumor would not. So think of it from the different perspective of the stakeholders. From the patient point of view, what will the result tell me about my cancer, which is really what he or she wants to know. From the physician, who can now order innumerable numbers of tests, why should I order this one as opposed to another one? Will it help the result? Will the result help me manage my patients? From an investigator point of view, you want to streamline research. From a sponsor point of view, will it accelerate the development of the drug? From the regulator, should I clear it or qualify it? That's given an approval. And for an insurer or third-party payer, should I pay for the test? And many of us have spent time on the phone with third-party payers trying to justify the performance of a particular scan. So to give you some examples, first, as you saw from Dr. Rathkoff earlier, you'd like to show that the mechanism of the drug and the reason you brought it into clinic is correct. So with using the anti-androgens, enzalutamide and ARN-509, we were fortunate to have worked earlier to develop a fluorinated dihydrotestosterone PET scan, which, as you will see, shows first that, in fact, the mechanism was correct. It was supposed to block androgen uptake, and it provided the optimum dose. So here you can see this is the cell line that Charles Sawyers used to screen and identify MDV-3100 or enzalutamide and ARN. Again, this was a situation with overexpressed AR, where bicalutamide actually makes the tumors grow faster. It had the unique mechanism of action of not only blocking the uptake of the drug, but blocking downstream effects in terms of binding to DNA and nuclear translocation. The nuclear translocation will become relevant as we start looking at the receptor in individual cells. But again, here is the first patient we studied with enzalutamide, pre-treatment diffuse uptake, post-treatment, again, complete blockade. Initially, this was scored manually by looking at the 5 hottest lesions, and now you can see that in each of the individual lesions that was counted with some newer software, we saw a decline in virtually every lesion from the pre-therapy to the post-therapy. But note here that there is a range of uptake of the tracer in individual lesions, which we ultimately saw in individual cells, as we will discuss later. So with the software now to score all lesions, as you heard from Dr. Rathkoff, an optimal dose of 240 milligrams per day was established. This matched what was seen preclinically. Both of these are response indicators, as I will show you later. Just because we saw a decrease in the tracer uptake, confirming proof of mechanism, we did not see a response in every one of the patients. Now, one of the major areas that we've tried to focus on is, can we reproducibly measure changes in bone and show that those changes actually reproducibly associate with survival? And the key is, how strong is that association? We've also looked at circulating tumor cells based on evidence which shows that if there are tumors that, if there are circulating tumor cells in the blood versus no circulating tumor cells, overall these patients do worse. That is true whether they are at baseline, that is pre-treatment, and also post-treatment. And in the development of androgen receptor and androgen receptor targeted signaling agent inhibitors, we were concerned that the drug itself could actually change PSA, which would not necessarily indicate that you were affecting the tumor favorably. So about every week, I get a printout of the latest publications on circulating tumor cells, and now there are almost double digits per week, increasing quite dramatically. But actually, there is only one technology that has passed the level of an FDA clearance, which means that its measurements are completely reproducible. It can be performed in a clinical setting and can actually use to guide medical management. So this is an EpCAM-based immunomagnetic selection process. It basically uses a ferrofluid which has EpCAM attached to it. This is designed to capture cells that express EpCAM. A series of immunohistochemical stains are then performed, first to identify the nucleus. A number of cytokeratins are then stained to show that these are in fact epithelial in origin, and CD45 is used to make sure that they are not in the mononuclear cell family. And there's a very consistent report which reports the number of cells that meet the criteria of an intact cell with the nucleus surrounded by cytoplasm, cytokeratin positive, CD45 negative, DAPI identifying the nucleus. So again, these are cells that would meet the criteria. These cells, in fact, are undergoing apoptosis. They would not meet the criteria. These are the cells that are counted. And at baseline, that is pre-treatment or post-treatment, the higher levels are associated with a worse outcome. Now, you saw the waterfall plots for both Abiraterone acetate plus placebo, as well as enzalutamide. We were obviously very encouraged by this, but within the trial, we also embedded, Dr. DeBono and I, the study of circulating tumor cells. So you can see that there were a proportion of patients who met the 50% decline criteria. There are also a relatively high frequency of abnormal or unfavorable circulating tumor cell counts. And what was of interest, that all of these populations were clinically defined, that is the post-chemotherapy treated castration-resistant disease. And note the consistent performance in a trial at the UK and the 2 trials conducted at Memorial. Clinically defined, consistently performing assay. And note again the frequency that the unfavorable counts, that is high counters, became favorable, that is 4 or less. Again, fairly consistent results. And with this degree of consistency, we were able to convince the sponsors that it would be a good idea to explore circulating tumor cells as a question in the phase 3 trial. So this is the last part of the clinical validation. In the context of the registrational trial for Abiraterone, 2-to-1 randomization, Abiraterone plus Prednisone versus placebo plus Prednisone, primary endpoint, overall survival, a circulating tumor cell number question was embedded. And importantly, we contacted the agency beginning in 2007 when this trial was first designed to discuss with them the process that we plan to follow. So what is critical is how strong is the association of your post-treatment biomarker with survival. And what we did is we were looking to see if the treatment effect on the biomarker, which we postulate will be associated with survival, explains the survival. And to associate this, we used the Prentice criteria to see if we can establish or show that the biomarker that is proposed would meet the criteria for surrogacy at an individual patient level. I don't expect you to memorize this at this point, but I will walk you through it one step at a time. So in the context of the 1,200 patient trial, we were able to collect circulating tumor cells sequentially from pretreatment to week 12 on 711 patients. This is an international trial. The samples were run at Sloan Kettering or at the Royal Marsden. And the first thing you need to show is that the treatment affects survival in a favorable way. So again, in these 711 patients, a significant improvement in survival was demonstrated, satisfying criteria number 1. We then explored the data and came up with 3 risk categories based on the circulating tumor cell count at 12 weeks, as well as the LDH, unfavorable CTC counts, high LDH, a high-risk population, intermediate, a unfavorable CTC count with a LDH that is in normal range, and low risk, including the patients with a CTC count of 4 or less. So what you'd like to see, the second criteria is that the treatment must have an effect on the proposed biomarker. So what you would expect is that in the patients who are in the high-risk category who are receiving the drug would have a lower frequency of unfavorable, of high-risk biomarker criteria. So if you notice that in the prednisone alone group, 33% of the patients had unfavorable counts, as opposed to 15% in the abiraterone plus prednisone group. And a higher proportion of patients were now in the favorable risk category versus those who were in the prednisone alone group. This satisfies the second Prentice criteria. You want to show that the biomarker you proposed has a significant impact on survival. And you can see there's a significant difference between the patients who are in the favorable risk versus those in the intermediate risk and those within the high risk category. And while it may be difficult to sort of try to look at this in terms of hazard ratios, the discriminatory power of this was quite high. This is a measure called the concordance probability index, almost reaching 0.8, which satisfies the third criteria. But if you actually look at this in terms of 2-year survival probabilities, it's much easier to see that the patients who have a high risk or remain in an unfavorable category at 12 weeks have a very poor survival, only 2%, versus 46% of those who are in the low risk category. Now, the fourth criteria is one that's called conditional independence, and this is the most difficult one to satisfy. And what it shows that regardless of what your risk classification is in terms of the group you started treatment in, once you account for the biomarker in both the prednisone plus placebo versus abiraterone placebo, the survival benefit should disappear. So what you're looking at here is the low-risk patients at 12 weeks, independent of where they started, whether they were in the abiraterone plus prednisone group or the placebo plus prednisone group. And you notice within each of these categories, there is an overlap. So the treatment effect disappeared. And this satisfies criteria 4, which essentially shows for an individual patient, this did meet the criteria for surrogacy. Now, again, this will give you an idea of the scope of the interactions with the FDA. We have been studying circulating tumor cells within a number of different drugs. We've included it within the enzalutamide development. We've included it within the arteronol development, ipilimumab, cabozantinib. Each of these are the trials. You can see the regulatory history of the FDA discussions and approvals with each of these compounds. But these are the biomarker discussions. This is with the CDRH branch of the agency. And we will be going shortly to the agency to discuss the results of the surrogacy analysis. Again, this will be reported at ESMO. And we have now formally filed this results with the agency, and we'll be speaking with them in February. But what we're really interested, I think, one of the real potentials of blood-based biomarkers, and in particular circulating tumor cells, is to enable us to practice precision medicine, because the circulating tumor cells actually reflect the tumor at the time that you're considering treatment. One can do a biopsy of a lesion, but as I will show you, not all sites of disease are the same. So one could argue that from blood, you will see essentially a sampling of multiple individual sites. So again, looking at the waterfall plots, very similar for enzalutamide or abiraterone plus prednisone, there's clearly a range of sensitivity. Some patients have no, essentially resistant immediately. Others are quite sensitive. So this suggested that there is a presence or within tumors of various biomarkers or predictors. Again, we've come up with a classification, and these were based on the average PSAs of about 30 patients each who really did not respond, the so-called de novo resistant, as Dr. Rathkoff mentioned, the drifters. Again, these are patients while their PSA is going up. In some cases, their disease is not progressing. That's why we can, we believe, appropriately monitor them over a period of time. And these are the true responders. Now, there have been a number of postulated mechanisms. You've heard of some. Dr. Chen has worked on cooperativity between the TMPRSS-ERG and PTEN pathways, both very frequent alterations. Again, these appear to be highly resistant and aggressive tumors. You heard about the reciprocal feedback as presented by Brett Carver and also in Charles Sawyer's group between the androgen receptor signaling and PI3K signaling axis. And there have been recent publications looking at mechanisms of acquired resistance. So Dr. Minabalbas identified a mutation in the androgen receptor at position 876, which comes up over time in tumors that become resistant to enzalutamide. And Vivek Arora recently showed that the glucocorticoid receptor can actually co-opt the androgen receptor and induce AR signaling. Now, if you look at the individual lesions I showed you earlier, we saw that there was a range of uptake of the fluorinated dihydrotestosterone tracer. But this is the patient's individual PET scan of the FDG PET scan. Again, you can see quite a range. There are some tumors where the glucose uptake goes down. There are others where there's actually an increase over time. And one can get a very different result if you're doing a biopsy of this lesion versus these lesions. So again, you're seeing in vivo, by using PET scans, that the disease in this patient is quite heterogeneous in its sensitivity. So we were looking for a way to try to characterize this heterogeneity to the point where we can actually help inform decisions. So we recognize this. So from a circulating tumor cell, we were looking for a platform that would enable us to isolate multiple cell types within the blood, as opposed to the EpCAM-based capture method on an individual cell basis. So we were working with Epic Sciences in La Jolla using a technology that was developed by Peter Kuhn at Scripps. And what essentially the technology involves is taking the Buffy coat and essentially putting them on proprietary slides. We make about 12 slides per patient. They are then stored, and once the fixation has occurred, they remain stable for molecular and protein analysis for over 2 years. Then there is, again, a staining procedure that is performed, and you can start to see that there are now different cells, this being a circulating tumor cells. This is a stain for cytokeratin. And there's an imaging system which will scan the slide and identify individual cell populations, and then this is interpreted, and I will show you the reports that are in fact generated. So again, there's about 3 million events on the slide. The scanning software, again, will identify here a cytokeratin positive cells. These are CD45. You see that there are red cells. This takes between 5 and 10 minutes. And it can remember the position. So in fact, if you want to go back and interrogate that cell by protein analysis or by FISH, you can identify the same one. And again, if you blow that up, you can now see that this is a cytokeratin positive with a nucleus. This would meet the definition of a circulating tumor cell. And again, in this particular sequence, DAPI positive, CD45 negative, cytokeratin positive, and androgen receptor positive, which I'll show you in more detail. So again, there are a number of different cell types that we're seeing. The traditional CTC is very similar to the Veridex definition, although we can't say it's one-to-one. There are a large proportion of cytokeratin negative cells, particularly in later stage disease, which are believed to have undergone the epithelial mesenchymal transition, which is believed to be part of the process whereby they metastasize. Again, CD45 negative, cytokeratin negative, stain these cells for prostate-specific membrane antigen, the prostate-specific marker. They are positive. You can identify cells that are undergoing cell death. Now you have the opportunity to look at changes in cell death over time as a pharmacodynamic measure. And this is as yet uncharacterized population of relatively small cells, which appear very late and may in fact represent some of the neuroendocrine and particularly lethal cells. And this is now a very intense area of focus. So simply looking at a cohort of patients with progressive castration-resistant disease, you can see a range of cell numbers, but you can also see, looking at the androgen receptor, very similar to what you saw with the PET scan, a range of expression on the cells that meet the criteria for circulating tumor cells. You can then look at different cell populations. In red are the cells that are undergoing apoptosis. And you can see that, in fact, how do you represent this in a database is something that we're, in fact, working on intensively. We can report cell numbers. We can report varied protein levels. We can average the protein levels. Each of these is a biomarker whose significance we will ultimately have to prove. But one thing in particular is we can start scoring where is the androgen receptor. So here is the typical androgen-driven prostate cancer cell with a nuclear staining of the site of the androgen receptor. Here's one in a post-enzalutamide treated patient where in fact the drug has had its effect. It is no longer in the nucleus. And one can make the argument that if you see a patient where in fact the predominant androgen receptor is nuclear, perhaps that is a patient in whom an enzalutamide or ARN may not be appropriate. So just this is what we call our patient on a sheet. This comes directly out of our clinical databases. We track the history of the patient, focusing on the prior treatments that the patients had received. Here you see his time course. The patient had a rising PSA, rising circulating tumor cell counts using the Veridex assay, did not respond to Zytiga, and then went on Xtandi. You can see a precipitous drop in PSA, drop in circulating tumor cell counts. This patient had relatively predominantly nuclear androgen receptor localization, again, moderately high level of expression, and was PTEN wild type. Obviously, there are multiple other analyses that could be done, but intuitively, you're looking at PTEN status, where the androgen receptor started, and this patient responded. The second case did not respond, and again, he had although he had nuclear localization of the androgen receptor, this patient had PTEN loss. And in the reciprocal feedback hypothesis, this is a patient one predict would likely have a lower response rate. So again, this is just a initial overview of the type of information that can be generated. Each of these measures that we propose will ultimately have to be tested prospectively to see how informative and reliable they are. But now that these trials are starting, this is the trial that Dr. Dana Rathkopf showed you earlier. She'll be looking at 2 particular cohorts. She'll be looking at patients who have primary resistance to abiraterone acetate, as well as those who have acquired, the so-called drifter patients, who've been on treatment for a period of time and whose disease is later progressing. And again, we will be incorporating the EPIC platform to look at the circulating tumor cells, both pre-treatment and on treatment, to see if there are biomarkers that we can develop to help us predict ahead of time whether the patient is likely to respond or not. So with this assay in hand, we are now looking at this particular biomarker platform with a number of different targeted agents, included in these trials will be imaging as well. So I've tried to give you a sort of the history of how biomarkers are considered for the context of use. Again, there are a clear set of rules and a clear regulatory path. You've seen how it can be used to assess pharmacodynamic measures. I've shown you the process whereby we collaborate with the agency to try and develop a surrogate for survival that can be used for regulatory approvals. A biomarker that is qualified can be used by anyone in a regulatory submission without filing the biomarker result itself. And clearly, where the future has to focus is on the area of the predictive biomarkers, which will enable us to choose treatment so that we do our best to ensure that the treatment we select is one to which the patient is most likely to respond. So again, to give you an example of the scope of this work, of a wonderful team at Sloan Kettering, members of the GU Oncology Service, the clinical laboratories group where we perform our tests, nuclear medicine, the research efforts of Dr. Sawyers, and you'll hear shortly from Dr. Chen, our statistical colleagues, pathology, collaborations with Cold Spring Harbor and sequencing, EPIC Sciences, the sponsors who've enabled us to include these measurements within their trials, and a very close and very productive collaboration with the FDA, who are really interested in us being successful. Thank you for your attention.